Well, good morning, everybody. Thank you very much for being here. I'm going to actually ask if they'll bring the house lights up a little bit, because you notice the title is Conversation, which means it shouldn't just be me. It should be a little bit of back and forth, and the talk is going to be short, and the time for conversation and questions much longer. So I really would encourage you, if you have questions, you do your best to build up the courage to ask them, because I'm happy to take my best stab at it. You heard I said best stab at it. I'm not ChatGPT. I do use open evidence, just to say, but nobody has all the answers, because everything has nuance. A lot of what's going on in your life is often implicated or changed by things around and other components of your healthcare and other medical problems that you have. The second thing I wanted to say, I heard somebody say earlier that we would need somebody right after me to come up and tell what I said. And if this is true, I totally failed in my goal today. So I tend to be kind of a simple guy. My goal is to take concepts and try and make them easy to understand. If I failed in my task, please get up and say, Steve, what you had to say was complete garbage because I couldn't understand a word. Here's what I'm asking, and I will do my best to clarify it. And the reason I think that's important is the point that was made in the talk before. Yes, you are the CEO of your healthcare. That is an important concept, but a good CEO doesn't take only their own advice and doesn't take every decision about everything. A good CEO mobilizes a good team, hears from the team, synthesizes the information, makes wise decisions because gets wise input. So all of that together gets a good team. And so I think as you're navigating your journey, be critical of the information, have an inquiring mind, think it through, get input from professionals, get input from family, and then kind of decide as you go along. So my goal today is just to focus in on side effects and complications of the disease. And really, as I say, I'm going to take maybe 20, 25 minutes just to tell you kind of key concepts. But then we're going to have some roving mics, I'm hoping, and I'm really going to encourage you to ask questions that are more pertinent to your circumstance. Because I do think sometimes you can have long, boring talks. The lights go down, everyone goes to sleep, coffee comes, and it's like, great, but I missed what the guy had to say because it really wasn't very relevant to me. So what do I hope we'll talk about? The first thing I think that's really helpful, at least in my mind, is to understand how. How does Waldenstrom's cause complications? Why do I get problems? And you're going to see I'm going to talk about three things. One is the effect of the cancer cells directly in your bone marrow. And what is that doing? The second thing, and you probably learned a little bit about this already, is that the IgM is a big molecule. And because it's big, and oh, by the way, it's sticky, it causes problems because it thickens the blood and it sticks to stuff. And when it does that, I'll show you in a minute, it causes a number of medical problems. And then thirdly, we're doing our best to get rid of those cells. And so when we go after them, we love to believe that we're targeting the cancer cell. And we kind of are, but not perfectly. So there's going to be a little bit of, shall we say, collateral damage, where cells that weren't cancer cells got caught in the crossfire, and that's the effects of treatment, and those are going to have some side effects. And then I think important to really talk about what complications do you get. And I alluded to this a little bit, but you can see that if the cells are taking up space, they're going to cause problems. Secondly, I'm going to talk about the physical structure of the IgM molecule and why that's going to cause problems. And then, as I mentioned, the stickiness of things, because it sticks to stuff, when that happens, the body hates antibodies stuck to stuff. When it sees that, it will chew it off. There are cells in your body called macrophages. I call them the trash collectors of your body. They would just munch that off. And when they munch that off, that's not usually good from whatever got munched. So again, I want to just share a little bit about what that means. So I think it's useful, at least it is for me, to think about Waldenstrom's as really a disease with two problems. On the one hand, you can see it on the left, there are these lymphoplasmacytic cells that are causing part of the problem. And note I said part because it's not the entire problem, and there's a kind of a teeter-totter, if you like. Some people have more problems with the lymphoplasmacytic infiltrate. Other people have more problems with the second thing, which is the IgM protein. So that's a schematic, a little drawing, if you like. It doesn't really look like that if you were to see it under an electron microscope, but you can see it actually is an antibody that's got 5 antibodies glommed together. And why do you need an IgM antibody that looks like that? Well, IgM is your quick and dirty response to any kind of infection. I often explain to patients that if you walked out of here and you breathed in the flu virus, how do you fight the flu virus? Well, pretty much you have those trash collectors in your body and other cells called dendritic cells. They call them antigen-presenting cells. They're like your hunting dog. They go grab something and they bring it back and say, see what I found? And it shows the immune system this virus. It says, this doesn't look good. It could be a threat. Lymphocytes, their job, particularly B lymphocytes, and you've heard a lot about B lymphocytes because this is kind of the target of many of the therapies we give. B lymphocytes, when they see a threat, change into plasma cells, and when they do that, they make antibodies, and antibodies are like missiles. They're going to kill the flu virus. So a few things that are important with that process. You heard me say it goes from a lymphocyte to a plasma cell. So when you say, I have Waldenstrom's, you have a disease called a lymphoplasmacytic lymphoma. See, lymphocyte to plasma cell, right in the transition between the two. That's when the cell made a mistake. That's when it got stuck. That's when the cancer developed. But why is that important? Because a lymphoplasmacytic cell, the one that is becoming a plasma cell, the first thing it does, it sends out the quick and dirty response to that virus. That quick and dirty response is the IgM molecule. It's big. It's not very specific yet. It's super sticky. Its job is just to corral this thing. Keep that virus controlled while you make a much more specific antibody called an IgG. But again, why is that important when you have Waldenstrom's? If you have too much of that antibody, especially if your numbers get into the thousands, you've got a big molecule floating around making your blood much thicker than it should and making things much more stickier than they should. And again, remember, this is normal physiology gone bad. So again, just the takeaway from this slide is lymphoplasmacytic lymphoma, that's the bone marrow and other organ infiltration, and high levels of sticky IgM protein, that's also one of your risks and problems. This is just a little bit more information about what that cell looks like. So this is when you have a bone marrow and they suck the bone marrow out of your bone marrow. And I'm hoping you were kind of asleep when they did that. Most people will remember this very vividly if they weren't. But the reason it's important is that they're going to the factory. They're going right to where the cells are, and they're drawing out the cells. And you can see carefully arrowed there are plasmacytoid cells. And they got this blue kind of color, and they've got those little red, sort of darker blue nucleus that's off to the side. But the blue stuff is IgM. It's loaded with IgM protein. You've heard a lot about MYD88. That's a mutation or a little genetic change in the code that codes for a protein that sends the messages to cells. So why is MYD88 an important thing in Waldenstrom's? Well, it's kind of like the messaging system from the outside of the cell to the inside of the cell. And interestingly, when you have this code change, you actually get like a megaphone effect happening inside the cell. So everything is really loud inside the cell, and so the cell is super agitated, and it's making much more protein than it should. Why is that important? Well, one of the therapies are BTK inhibitors, which basically shut off that wiring program and stop the cell from having this noise going on so everything calms down cell makes less protein, goes to sleep, everything gets quiet. Second thing you've heard a lot about probably already is the CXCR4 mutation and other mutations. That has to do with what's called homing, the ability of the cell to travel around. So remember I told you in the beginning, lymphocytes watch for infection. They travel around your body looking for troublemakers. Why is this important? When you hear you have cancer, the very first question I commonly get is, what stage is it? The biggest problem in Waldenstrom's, that's a meaningless question. So put it into ChatGPT, see what you get. And why is that meaningless? Because a normal lymphocyte is born in your bone marrow, travels to the lymph nodes, camps out in the lymph nodes, and then travels to any tissue in your body. So if it makes a mistake anywhere along that part, that's where it tends to hang out. So many hang out in the bone marrow because remember, that's where it's born. But the staging system calls that stage 4. So everyone gets really bent out of shape because Open Evidence or ChatGPT or whatever told them that stage 4 is bad. And to be frank, in this disease, it's not any different to stage 1. So at the end of the day, not a particularly helpful kind of piece of information. However, why is it important to know about CXCR4 is because CXCR4 is the homing, shall we say, the little radar on the front of the cell that helps the cell know where to go and helps to know that it needs to go to the bone marrow or be in the bone marrow or go back to the bone marrow. If you have a mutation in that, you kind of like it's like your GPS isn't working, or it's a little bit like your car when you've got sort of driver assist and now suddenly it's driving, you're kind of hanging on to it like crazy because it's doing its own thing. A little bit like that, your cancer cell now has become a little bit more random, if you like. So that was the one thing, just to remind you about lymphoplasmacytic infiltration. The second thing, just to take a minute to talk about, is the big protein. So remember I said this is your body's quick and dirty response to an infection. You send these big proteins out quickly. You're corralling things while you're trying to get a much more sophisticated response to the virus. But these big molecules are the problem. They're sticky, they make the blood thick, and they can actually pull tissue. They often are they're sticking to things that are self, and that's not actually great. They stick to nerves, they stick to other red cells, they stick to tissue. All of that causes complications. So as I just start out, just to take a few minutes to say, well, how often do these side effects and complications happen? So this is an old study where they just took around 200 people and they just said how many people showed up with what degree of symptoms. What were the presenting symptoms on average? I think the important thing to say is that a quarter of patients didn't know they had it until they went in for a doctor's checkup and some test came back and said something. So they don't really have any symptoms. But I think also important that quite a lot of people have anemia. Again, they may not feel it, may not know it, but I'll show you in a minute why they have it. And the important thing there is that can be something that really contributes to some of your symptoms. This is older data, so again, to the whole question we said earlier, just making sure that you keep the source of your information as up to date as possible. I don't think hyperviscosity occurs right now in about a third of patients. I think we're much better at picking things up and considering treatment before you get hyperviscosity. But hyperviscosity is really trying to pump, strawberry jam around your body. The blood is all kind of super thick, and because it doesn't go very well, it doesn't deliver oxygen very well, you don't feel very good, and that's what hyperviscosity is. I'll talk more in a second. Some people, and you heard a comment earlier about Richter's transformation, that's when the cells change gears and they make another genetic mistake. And when they do that, they start to speed up their growth pattern. And when they do that, many times you get loss of weight, you get fevers, you get drenching sweats. And again, if you think to yourself, why would you get that? Well, remember, this is your immune system messing up. Think back to a time when you really had bad influenza. and you were all kinds of feverish, and you were all kind of sweaty, and you had all this strange, and you didn't feel like eating. Well, that's what happens when your lymphocytes are out of control. So if they're out of control when you have a cancer problem, you can get similar symptoms. Now, take a few minutes to talk about bleeding. So many people with Waldenstrom's can suddenly find that they brush their teeth, and good gracious, there's like almost a bloodbath when they spat out, and because, again, your coagulation can be interfered with by these proteins. And then I mentioned things sticking to like nerves and other tissues. Neurological symptoms can often happen. I'll talk about this in just a second. But neuropathy happens when this protein sticks to the neurological sheath. If you can think of it like electrical wiring. You know, there's a wire and then there's the plastic coating on the outside to stop the wire from short-circuiting. Well, if you strip the wire of the coating off and you let the wires touch each other, well, there's like all kinds of sparks kind of happen. So imagine if you've got an antibody that sticks to the sheath that's on the outside of your axon, the nerve in your body, and the trash collectors come and chomp it off, and it's like they're pulled off the coating of the wire, and then the wires touch each other, and you get all kinds of, ooh, that hurt, or ow, that's aching, or whatever, which are neurological symptoms. So I'm going to just take a few minutes and talk through these in a little bit more detail, but as I said, then my goal is for you to have an opportunity to ask questions that are pertinent to your circumstance. So bone marrow infiltration. So remember I mentioned that right in the beginning, and I just wanted to highlight, this is what it looks like under the microscope. So the pathologist who's looking at your bone marrow does what is called an H&E stain. That's the purpley blue stuff on the left, and basically just says, man, there are way too many cells in this bone marrow. Fun fact, the amount of bone marrow you're supposed to have under the microscope is 100 minus your year or your age. So someone like me, I'm 62 years old, so I should have no more than about 38% of what they're looking at should be cells. The rest is going to be fat. I don't really think I was that fat, but there you have it. The bone marrow infiltration, though, is if you look under the microscope and you do special stains, this is now for proteins like CD20 or CD138 or CD38. These are little proteins that are on the outside of the cancer cell. And the reason they're looking for it, cancer cells are copies of each other. So when you see lots of the same protein, you know these cells are all little copies of each other. And you can see a lot of brown on the picture on the right. So that's where there are a lot of these lymphoplasmacytic cells in the bone marrow. Again, why is this important? That physical presence messes with the ability of the healthy bone marrow to make the blood that it's supposed to be making. And on top of that, you've probably heard a little bit about the cytokines and other proteins that are often made. And when that happens, there is a protein called hepcidin, which is kind of like the switch-off bone marrow production protein, and it really works against iron metabolism. So because of that, you don't make a lot of good quality red cells, and you potentially become anemic. That was just from the cell problem. But remember I said these are cells that make antibodies. The important thing is these cells make good antibodies as well as the monoclonal antibody. So you need the good antibodies, you don't want the bad antibodies. The challenge, however, is our treatment isn't very specific. It just stops the cells that make the antibodies. So it stops you from having good IgM protein, but particularly the monoclonal protein. We want that. But unfortunately, will stop you from making many immunoglobulins, including other IgMs that are normal and healthy, and IgG, which is the one that is that highly specialized and specific antibody. So again, why is that important? Many people will find that they suddenly get a little more susceptible to infections, often need to go on IVIG replacement. Basically, we're giving you somebody else's antibodies to replace the antibodies you're not making. And I think there we go. So I'm talking here about infiltration. So you saw me show infiltration into the bone marrow. Now I want to show you infiltration into other tissue. So remember how I mentioned these cells like to travel around. Here is a disease, not very common. It's called Bing-Neal syndrome. And what is that? That's physically these cells going into the neurological system, into the brain or into the spinal cord or something along those lines. And typically people end up with kind of like neurological symptoms. They suddenly don't think so well. They may even have stroke-like symptoms. And important here just to highlight that the treatment is targeting these cells. And we have to pick well when we come to actual drugs that we would use, because not all drugs get past what's called the blood-brain barrier, the coating around your brain, because your brain actually doesn't want toxic stuff like chemotherapy to hit it, and so it keeps them out. And so we have to pick wisely as to which the treatment is that we would get in. But again, what principles I'm trying to show you here is on the one side of the spectrum is the physical presence of cells in the bone marrow or, for example, in the brain. Now I want to just talk a few minutes to say, if you took the cells and you set them aside, but you went to the other side of things and now you're looking at the protein, and you go, well, what happens with that circulating protein? What are my risks? What are the potential side effects? Well, I mentioned hyperviscosity a few times. So hyperviscosity is the fact that your blood is now much thicker than normal. A little bit like when you make Jell-O. You know, when you pour it in the beginning and then over time it slowly sets. So pretty much the extra stuff that you put in there is making the blood thicker and thicker. And how do you notice that as a patient? Well, sometimes the places where your blood flow is the most at risk, you can suddenly get ulceration. So you see that on the top left. That's what's called a watershed area, meaning the two blood supplies are overlapping. And so if there's any compromise, that's a place where skin can very easily break down or tissue can break down. You see that patient's actually got ulcers because oxygen and blood supply is compromised. On the bottom right, you see somebody that's starting to get what's known as Raynaud's phenomenon, where they actually are getting not enough oxygen to their fingertips, and you can see how white those fingertips went because actually the oxygen delivery is substantially compromised. The patient in the middle, you can just see that white stuff. Just know that on an MRI or a CT scan, white is never good. So lots of white isn't a particularly good thing. This is the kind of thing when suddenly the spouse of the patient goes, man, he or she has suddenly become dumb as a brick. Every time I ask them questions, they say all kinds of weird stuff. And or they start to notice that they're actually starting to have trouble seeing or trouble thinking straight or hearing because oxygen delivery to critical parts of the brain is now compromised. What you're seeing on the right is basically retinopathy, so that's a picture to the back of your eyeball, and they're looking to see, and they see almost what they would call sausaging of the tissue. So you see the little blood vessel, and then there's like this big blob of goop going past, and you can almost see it sort of go squidgy kind of as it travels down. So that kind of stretching of the blood, of the little blood vessel, many times leaking of the blood vessel, can cause visual problems. People can suddenly find it very difficult to see clearly, often blurry vision, or sometimes even vision loss. I'm going to take a few seconds to talk about cryoglobulinemia and cold agglutinin disease. These are fancy names, but you can hear the word cryo or cold in it. So those antibodies actually are sensitive to temperature. So sometimes the hotter or the colder the temperature around you, the more the blood is actually likely to kind of become more congealed, if you like, and actually stick to things. So this is what's called cryoglobulinemia. If you live in Minnesota like I do, it gets pretty chilly. Suddenly the antibodies will actually form complexes, and the complexes will stick in the tissue and cause a leukovasculitis, like you can see there. That actually causes a lot of inflammation and problems. Similarly, you can get what's called cold agglutinin disease, where every time the temperature goes down, the cells actually stick to the red cells. And antibodies stick to the red cells, and they cause the body to take the red cells out of circulation, and people get what's known as hemolysis, red cell breakdown. So they will tell you, the moment it's cold, I suddenly notice the tip of my nose goes white, my fingers go all white, and suddenly I feel super tired. And when they check my hemoglobin, it's 8. And then when I moved to Arizona, it's fantastic because I'm back at 16 on my hemoglobin, and I never have those problems. That's cold agglutinin disease. You can see it right here. I mentioned the bleeding problem. You can see somebody here with kind of very sort of gums all looking bleeding. You can see, or very bloody. You can see the bruising in the skin. You can see the nosebleeds. And this has to do with that protein interfering with other proteins in the body. Those other proteins in the body help with a coagulation cascade, so it causes you to clot if you're at risk for bleeding. And if you mess with that, suddenly you're at risk for having a bleeding problem. Peripheral neuropathy, I touched on that a little bit earlier, but again, thinking back to the wiring in your system, thinking to the plastic coating that may be stripped off. When that happens, what you're seeing here is an EMG trace on the side, because if you have a test, they actually measure the conduction through your nerves to test that. And if you look carefully at this person's foot on the left side, you can see that the arch is kind of super high, and the actual foot is a little bit kind of in a Z kind of shape, if you like. And basically what's happening is the nerves are actually affecting the muscles, and the muscles are now actually contracting in a way that the actual foot function is being compromised. So it doesn't only affect the actual sensation, it can actually affect muscles function and conduction. This is a process called systemic amyloidosis. So what happens now is this protein, which is so super sticky, attaches itself to tissue. And sometimes it's the whole protein, and sometimes it's parts of the protein, and it all depends where it sticks as to what kind of symptoms you get. So the patient on the left with the big tongue, they called it macroglobulinemia, and you can see it's a big tongue because there's actually an imprint from the teeth if you look. So it's like the tongue is trying to get around the teeth because there's no space in their mouths. You can see the orbital bleeding. This sort of happens many times. People will have a procedure done where they're bent over they were gardening and they bent over for a while, and the next thing their spouse goes, gosh, your eyeballs all went kind of like raccoon eyes. That's again the same process of these tissues being affected, and that's what we're checking in the bottom here. We're looking for what's called Congo red. They're actually staining this immunofluorescence. You can see that kind of greeny yellow stuff is all the deposition of the IgM in the actual tissue. Why is that important? That deposition will mess with your kidney function, will mess with your heart function, will mess with your bowels, will mess with your nerves, all of which can be pretty profound and impact your life substantially. It doesn't have to be the protein. Sometimes it can actually be the cells, and you can actually see here actually non-amyloid IgM protein in the cells. This is a disease known as Schnitzler's syndrome. So, I want to take a few minutes just to talk about what do you do when you have all of these symptoms. And then, as I mentioned, I really would encourage folks to feel free to ask questions. So the principles of how you manage this are really three things. It actually depends. That's why I took all this time to talk about what's causing your problem. Because one of the biggest challenges I have for many of the patients that come to see me, the first thing is to say, is the neuropathy that you're currently experiencing from IgM or from Waldenstrom's? I would actually put to you that probably more than half the patients actually have a neuropathy from something else. They have diabetes, they have some other problem. And the biggest challenge there is you don't want to get treatment for something that isn't causing your problem. So that's the first decision point that I think you need to think through carefully. When you then say, I'm sure this is actually from the Waldenstrom's, what from the Waldenstrom's is doing it to you? Is it the cells or is it the protein? Because again, exactly how you treat may differ a little bit. Generally speaking, you want to go after the cells that are making the protein, so that's fair. But I think, again, if you need to do something protein-wise right away, you might do, as I've got at the bottom here, what's called plasmapheresis, which in essence is an oil change. We're just going to go in, we're going to take out all your plasma and put in some other fresh stuff so that we can get rid of that high IgM level. So what would you potentially do if you're going to go after the Waldenstrom's? Well, chemoimmunotherapies are a strategy. You've heard some of that already. BTK inhibitors, proteasome inhibitors, BCL2 inhibitors, and monoclonal bispecific antibodies, CAR T cells, all target the Waldenstrom cell. That's going after the cancer, but many times this is a two-step process. You get rid of the cancer problem, it stops doing the damage, but the damage that already is there is going to take a long time to get better, and maybe it never will. So that's the second thing. You need to really focus in on improving the symptoms. So if you have a problem with neuropathy, there are medications. Remember how I said the wires are touching each other and you get that sparky kind of feeling? Well, could you just turn down the sparky feeling? That would actually help a lot. So there are medications that can help with that. If you have cold agglutinin disease, can you avoid triggering this cold antibody event so that you can have less in the way of the anemia? If you have a bleeding problem, can we actually work to prevent that by replacing some of the proteins that have been messed up with fresh that would actually improve things? If you have a problem with immunoglobulins being very low, can we give you IVIG, for example? And then, as I mentioned, sometimes just getting rid of the protein in a hurry, that's plasmapheresis. I would just remind you that that's just a Band-Aid. You're just going to do that as a temporizing measure. You're still going to have to do one of the other things because that's only going to work for a few weeks. This just talks a little bit about plasmapheresis, in case that's something you're interested in. Remember I said it's an oil change. It's really just you come in, we filter off your plasma, we give you fresh stuff back. Yours has got lots of protein. The one coming back doesn't have very much. Your IgM is going out. Very little IgM coming in. So it just revisits that kind of balance, if you like. Hyperviscosity doesn't usually happen until you get into the 5,000 or 6,000 milligrams per deciliter level. So if someone's saying I've got hyperviscosity with a protein level, IgM level of like 3,000, I would say you need to look a little harder. That's not likely. This is just to talk a little bit about the eye changes. You can see these arrows that are showing all the different ways in which those veins and arteries are being affected. The most important thing I think you can see just from the room, see how easy it is to see the arteries on the left and how much harder it is to see them on the right. On the left, they're all super big and swollen out because they've got all this extra IgM floating around. So that's really what I wanted to say as an introduction to the topic. I think most important, I'm more than happy to take questions, and I do think these are much more useful and interesting sessions when the guy up front shuts up and doesn't just keep babbling on. And so I wanted to give folks a chance to ask questions. I'm also happy to take questions. I'll even take questions on AI.
Thank you, Dr. Great presentation. Just was curious, what are some of the treatments for neuropathy to get the wires to stop sparking?
Yeah, so very good question. And I think, to be frank, neuropathy is one of the things that's a super frustrating problem. Because in essence, many of the therapies that help with the symptoms of neuropathy are modest in their benefit, and sometimes can make you feel a bit foggy. And so patients will take, let's say, gabapentin or one of those medications. As they get up to the dose that really seems to be helping, they find themselves really just feeling not all that clear. And so there's this, what we call therapeutic window, which is kind of narrow. But in essence, the principles there are that you want to treat symptomatically by trying to medications to improve things. Then there are other strategies. So there are ways in which, for example, if you have a drop foot, can you actually mechanically provide support for that? If you're having trouble with grabbing and opening things, there are all kinds of occupational therapy strategies that you can follow. So, and then triggers that make things worse, avoiding them. So you hear me hedge a little bit on some of the medications because sometimes they're very specific to you, but it's trying to navigate all of that. But it's a great question. You have the microphone.
I do, but they said there was somebody before me.
We'll take you.
Okay, so I have a two-part question. Why are some patients diagnosed with lower IgM, let's say under 1,000, and are highly symptomatic, me, and others 4,000 or above and don't have any symptoms. How does that work? And then the second
Well,
part.
hold the second question,
Okay,
because I'm a dumb
great.
guy and I don't
Okay,
remember the
great.
second question.
Okay, thank you.
But let me take your first question. So that is a very important issue that you're raising. Here's the thing that's really interesting. Your symptoms will show up at the same level every time. But your symptoms will show up at your level, and it'll be totally different to your symptoms at yours. So let's say you found you got a lot of symptoms at 4,000. I just made that number up. Another person has got 9,000 and didn't know anything was going on. Why is that? Well, the issue is the stickiness of the protein. So remember I said these are sticky, and you remember I said these are targeting self. But remember, they are monoclonal. So it's not a very productive and useful stickiness. It's just a general stickiness. So sometimes you made an antibody that is super sticky to something really critical in your body. So then when it sticks at 2,000 or 3,000, it's already causing problems. The next guy made something that is sticky only to pollen, and the pollen only comes up one time in the year, or in fact, it's not even a relevant pollen. That is, he might have made the antibody against the pollen you only find in Ireland when he was there on vacation. So those proteins then don't stick really to anything. They might have the thickening of your blood problem, but only when you get at super high levels. Yours is causing all kinds of issues because of its stickiness at much lower levels. So it's highly variable as to when people get symptoms. So that's why you don't hear me say there's a number at which everything magically happens, because it's only magically happening for you.
It's an important one because it comes up a lot. I was 571 and highly symptomatic. So it's just something people go, wow, how could you be that sick? And I was very sick. Now, go ahead.
Correct. No. And as I say, yours just happened to be, your body made an IgM against something that really wasn't helpful.
And the second part of this question is when to treat. So I ignored those things for about a year of symptoms. And then we usually don't treat unless it impacts your life, but that's very subjective. So I rode 60 miles on my bike, was fatigued, losing weight, and didn't, I just went on. So I think that's a question a lot of people have. How do you know when to treat? Because how it impacts your life could be different from the next.
100% agree with you. So I joke and tell patients you want to start treatment the day before you get symptoms. Little tricky to know when that is. But the point is just this is about quality of life. And I think one of the things that's very important to know, 100 years ago when I started in this field, we didn't have a lot of good tools. We had nasty chemotherapy that we had borrowed from myeloma and lymphoma. And we didn't really want to give nasty, unpleasant chemotherapy to people who had modest symptoms. So the sense was always just keep pumping the brakes until you really think you're about to go off the road, and then you do something. The point is, and many of you on these therapies, we have very different treatment now. We have treatments that are very well tolerated and potentially can improve patients substantially. So when to initiate treatment has actually come a lot further back from where we used to wait down the road. So again, to the whole thing about ChatGPT, making sure the data are current because things are changing and moving ahead. So to your point, I would say the goal is to get you running the marathons, riding the bikes, doing the fun things like you would like to do it. And so if you can do that with only modest side effects from treatment you would offer, you should absolutely do it. Here's the challenge, I think, and you're hearing new things, I'm sure, from your presentations yesterday. A number of these therapies that we're now testing, especially immunological therapies, are very promising. The challenge, however, is they're going to go after your immune system pretty hard. And that's good, because that's what's going to get a good result. But we're kind of swinging our pendulum a little bit now toward the potential for more side effects that may be a little more durable and long-lasting. So, again, always weighing up risks versus benefits, because many in the room will know I'm a big fan of, I think we're going to get a cure for Waldenstrom's, and it's coming. But until you know you can cure something, be careful to do maximum good for minimum side effects. Don't do maximum good for maximum side effects. That's not necessarily your best strategy. There was one back there. Here we go.
Ansell, regarding the Bing-Neal, you mentioned it affects the brain and the spine. Can spinal pain be a symptom of Bing-Neal, or can, another way to say it is, can Bing-Neal cause pain in your back?
And the answer is yes and yes, but the most important thing is to do due diligence to work out what it is. Because remember, Bing-Neal is because of the presence of cells in your brain or in your spinal column or wherever. It's not because of entrapment of the nerves for a different reason. It's not because of neuropathy, because as I mentioned, the wiring has been tampered with by your macrophages. So if you treat for the wrong reason, you're actually going to get an unsatisfactory result. But can you have cancer cells, Waldenstrom cells in your brain, in your spinal fluid, affecting the nerves as they exit from the spinal column? All of those are possible. You need to document it. And the way you document that is with hopefully a biopsy or at least with convincing imaging. Be very careful not to just treat on assumption, because you're going to need to get bit more specialized in what you're giving, because as I mentioned, not all drugs get where you want them to go when they've got to get past the blood-brain barrier. I'm looking wherever the microphone is, so somebody just got to help me out here. Right over there. Okay.
I'm curious, can either Waldenstrom's or BTK inhibitors affect cholesterol levels? And Dr. Google has different opinions on that.
Yeah, because the answer is yes, it can affect it. So we often see patients have changes in their levels both by disease driving it, but also because of therapy driving it. So the reason Dr. Google, maybe ChatGPT, maybe Open Evidence are all a little confused is because the data are really thin. So when you go to actually kind of put together the prediction algorithm, you're not working with a lot that really works very well. The additional thing that's super complicated about that is many people have cholesterol levels that are either elevated or whatever for other reasons, and also many people are taking statins. So now the question is just, what's doing what? There's actually quite a lot of literature around lymphoplasmacytic cancers in general that statins may be helpful in actually controlling the disease. The problem with that is just so many people who are getting their disease controlled for different reasons are on a statin. So which is doing what? So you can hear me hedging here because I don't know that we actually have an accurate answer. Well, let's see how about we do this? Hold your microphone for a second. She has a microphone. We'll start here and we'll come to you next.
Okay.
I'm new to WM. Last year I was riding my bike and got bit by a deer fly and developed like a large cellulitis. Is that something that could be related to the WM? And do you treat it with antibiotics, or do you just let it go, or what happens like that?
Yeah, so bottom line is Waldenstrom's is a systemic disease. So it's going to affect a lot of things in your system in general. So I can't always answer that question exactly because there are many pieces of data that I don't have, but I'll give you a general comment. If you have Waldenstrom's, and because you have Waldenstrom's, your body is spending so much time making monoclonal antibody that it's not making enough regular antibody, and then you get bitten by something, probably wasn't the bite, but because the skin was now disrupted, you have natural bacteria that live on your skin, and one of them jumped the fence and got into the system, caused a cellulitis. You probably would not have had any issue with that in the past because you had plenty of IgM. Now you might have less IgM than before, or IgG, or other antibodies, and so you didn't do a good job of clearing it out. That's one possibility. The other possibility is also you got too many cells in your bone marrow, and so your body got distracted with all of those cells and didn't make enough of the normal, what they call NK cells, the natural killer cells, the bouncers in your body whose job it is to go and get rid of those kind of things. And so you are immune compromised, not at a major level, but just at enough of a level that a nasty bug that got into your skin, you just weren't as good as getting rid of it. How do you manage it? You treat it the same as anybody else, but you treat it with an antibiotic, and you be a little more aggressive because you want to make sure you eradicate it as best you can.
My question deals with Waldenstrom's and effect on eyes, and is there a difference, and can you tell the difference between what Waldenstrom's does to an eye and a diagnosis of macular degeneration? Should you deal with that treatment-wise, and especially dry macular degeneration diagnosis, which there is no treatment right now except wet, you get injections. So what's the difference between them? Is there a difference between them? Can you find that? And then can you proceed?
So the answer is yes, very different. Very important to see an ophthalmologist. Very important to have what we call a slit lamp evaluation, where they're actually going to look deep into the eye to have a good look, not just the Steve Ansell version, which is just like, I'll take a quick eyeball there. You know, you're actually going to have your eyes dilated. They're going to have a good look because, yes, it's very different. I would also tell you that I see a lot of people that say, I have eye problems from my Waldenstrom's, and I would put it at 95% of them are wrong. The thing they have going on is something else. Because Waldenstrom's really only causes significant eye issues when your protein is sky high and out of control. If you don't have a sky high and out of control protein level, it's a little difficult to say your Waldenstrom's is your problem. Your macular degeneration may be your problem, and your diabetic retinopathy may be your problem. There are a lot of other things that it could be. So this is why we partner with the ophthalmology team closely, because you don't want to start treatment for your retinopathy for Waldenstrom's when it's really macular degeneration.
Can you?
Yep.
There we go. Better. My question is, with WM, have you seen cases where you've had multiple problems, such as von Willebrand's disease and neuropathy, or is it typically confined to a single problem?
Yeah, so generally speaking, those are uncommon, and so, having all of them happen in the same person is very uncommon. It does happen, and again, because we're one of those centers that sees a lot of Waldenstrom's, we certainly see it. And part of it has, again, to the point we made earlier about the nature of your protein and how sticky it is. Some of them are just phenomenally sticky. And I will just tell you, this is one area of research we haven't really paid a lot of attention to, is what we call protein folding, to work out why it's sticky. But yes, it does happen. That is super annoying because now you've got to kind of keep your eye on multiple balls, and playing any kind of ball sport with more than one ball is always a little challenging.
One of the side effects of a treatment is the loss of IgG. After a treatment stops, does the IgG come back? And if so, how long? How long does it take?
Yeah, very good question. And reminding you again, the goal of our treatment is to go after cells that make immunoglobulin. So the fact that IgG has gone down is not a failure, it's a known and somewhat expected consequence. Your question is really good because there are two factors there. The first factor is, what treatment did you give? So when you give a treatment that is like a BTK inhibitor, like a monoclonal antibody, for example, where you are simply basically taking out the cell or blocking the function of the cell, then you shut down the immunoglobulin production. But when you stop it, there is the opportunity for that all to regenerate. And data around rituximab, for example, showed that it usually takes 6 to 12 months for things to bounce back again. However, I just want to stress, so sometimes you didn't just do that. You did other things too. Then there's a compounding effect, which makes it a lot more difficult and takes longer for your IgG or whatever to come back. And then you have treatments like monoclonal or bispecific antibodies, or CAR T cells, which really are trying to get rid of that cell with a much more permanence to it. Those people take a very long time for the IgG to come back. And then a final thing that's a little complicated is, I might have an IgG level of 200 and no infections. You might have an IgG level of 400 and infections every other week. that's where we have to put some medical judgment in there to say, you deserve immunoglobulin replacement, and I can wait and not necessarily get it. So all of that to say, I don't know the answer, because it takes a lot of individualization of the patient, but even then, a lot of it we don't fully understand.
My question is about something that affects me that I rarely hear spoken about at these conferences, and it's about VM affecting one's lungs. Now, I had a cough that lasted for 2.5 years until chemotherapy stopped it within 1 month. And is that really the only treatment that there is for something like that going forward?
So let me just make sure I understood. You actually have Waldenstrom cells in your lungs, or you had a different effect on your lungs?
The answer to that is the biopsy was not clear. There was not enough material taken out to be absolutely certain.
So where I'm going with this is just lymphoplasmacytic lymphoma is on a spectrum. Very close to that spectrum is a disease called marginal zone lymphoma. Marginal zone lymphoma is notorious for locating itself in places where you're exposed to foreign antigen. So in other words, places you're exposed to the environment. It likes your skin, it likes your bowel, it likes your lungs. So could your disease have a little bit of a crossover kind of effect, meaning it's closer to a marginal zone than it is to a true lymphoplasmacytic lymphoma? Possibly. And then the bottom line is you need to go after those cells, because the cells, the presence of those cells in your lungs, for example, cause a lot of irritating symptoms and really kind of impact your life. And so that's, again, where getting rid of those cells or minimizing those cells can make a big difference. But you have a bit of a unique circumstance. Happy to talk through afterwards if you like. But that's not why you're not hearing so much at a conference like this, is because it's a little uncommon and it's probably more likely a close cousin.
Thank you.
2 more questions.
So, good morning, and
Morning.
thank you. This has been excellent. There's tremendous research, incredible progress being made, a lot of hope as a result of all of that. Is there any kind of an effort being put forth to improve the patient experience when it comes to the bone marrow biopsy?
So again, I'll do a little shameless plug for the place I work at. We do bone marrow biopsies sedated for everybody. And why? Unless you insist you want it awake, in which case I'll send you to psychiatry. But no, just teasing. But why is that? Because remember I said the factory is the bone marrow. And we often want to take another look at another time, because you want to know if the factory is still what you thought it was. And patients going, I had such a horrendous experience previously that I will never do that again, is not helpful. So I always tell people, you want it sedated, even if it's absolute hell, you can't remember, and that's perfect. You will, however, remember every time you sit against a firm chair. I can't really stop that. But I don't know that there's any research beyond just using conscious sedation. Last question, right there. Whoever's got the mic.
Okay,
Oh.
the difference between BKT inhibitor and CAR T cell, and is CAR T cell available, or is it in the future?
Yeah, so good question, and I'm sure they touched on this a little bit, but let me take a minute just to talk about what you're doing when you use a BTK inhibitor versus a CAR T cell, and maybe I'll just toss in a little bit about bispecific antibodies, because you probably heard a lot about this. So those are really, maybe I'll back up and say, there are three main strategies for treatment. The one is you use a chemical that kills quickly growing cells, like bendamustine, for example. And often we'll add in an antibody that sticks to the outside of the cell, like rituximab, and when it does that, the body hates things with antibodies stuck on it. So you're making the cell get shut down, and you're basically getting the immune system to attack the antibody-coated cell. That's BR treatment. Second treatment, to your point, is a BTK inhibitor. What's a BTK inhibitor? Well, you've got a little protein docking site on the outside of the cancer cell called the B cell receptor. And the B cell receptor has a little wiring system that tells it how to work. That whole wiring system is way too activated. I joke and tell people it's a little bit like the annoying kid in the neighborhood who's playing that game where they press the doorbell and run away, you know. But they're ringing the doorbell all the time, and the family's like, where is that kid? I'm going crazy. Well, you could catch the kid and give him a spank. No, maybe don't do that anymore. Anyway, you know, catch the kid. Or you could just disconnect the doorbell. A BTK inhibitor disconnects the doorbell. So it basically just shuts down all this messaging stuff. So everyone just calms down and shuts up and goes home. Third strategy is immunotherapy treatment. What you're now trying to do is you're trying to get your immune system that is ignoring the cancer to do a better job. So CAR T cells, or you take your immune cells, your T cells, out of your body and you send them to training camp. In essence, what you're really doing is one better than that. You are putting into those cells a docking site. You're actually like a magnet. So when you infuse those cells, they're going to stick to the cancer cell. When they stick to the cancer cell, they get very mad and they attack whatever they're right next to. Folks in the room who've heard me talk before will know I joke about this is like taking a cat. You put the cat in the bag, you shake the bag, you let the cat out, the cat comes out with its hair on end and it's like mad as can be, and it will scratch whatever it's next to. So basically you put it right next to the cancer cell, it'll take the cancer cell out really hard. But that's a more kind of intensive therapy and it takes a lot of resources. So a bispecific antibody is a poor man's CAR. Basically, you're going to take an antibody protein, they've engineered it that it will stick to the T cells, and then it will stick to the cancer cell. So basically, by sticking it to the T cell and the cancer cell, they've done the same thing. They've brought the two right up close to each other. It's a little bit like the cat being not quite as mad, but doesn't like how close it is to the dog, so it kind of just will scratch it. Same principle. Bottom line is, if you put all of that together, the most important thing is to weigh up the merits of treatment versus the risks of treatment. Because these all have different merits and different risks, and it's personalized to you, to what we heard in the previous conversation. You are the CEO of your healthcare. Get all the information. Make a joint decision with your caregiver team. Thank you.